Thank you, Jeff. I'd like to congratulate you in front of everybody for setting up this course, which has been very, very productive. It's a very broad topic. It's hard to cover it in 20 minutes. I tried to put the synopsis in your handout, and that should probably suffice for most of the outline that you need to study for the board. I'm just going to try and concentrate on some of the more controversial and new subjects in the broad topic. Thoracic aortic aneurysm is not a common case in the usual cardiac surgeon's practice. There have been in 1992 a total of 42,000 operations on the entire aorta. Out of those, 75% were abdominal, so you can figure out it's about 8 to 10,000 cases of thoracic aortic aneurysms are done annually in the country, and the number seems to be constant, is not changing. So I'm going to try and concentrate on the natural history. There is some new knowledge. We look at the survival and the predictors of rupture. The thoracic aortic aneurysms are considered to be systemic disease. They're usually in multiple sites. About 25% of patients have multiple involvement, either concomitantly or subsequently. The ascending aortic aneurysms mostly are dissections. The descendings are usually atherosclerotic or degenerative. And the overall mortality varies between 60 to 80% depending on the location. And the most important thing is 60% of the deaths in somebody with an aneurysm is due to rupture. Therefore, it's important to know the predictors of rupture. We know that there are three main predictors of rupture. One is the diameter. The 6 centimeters is the classic number that everybody mentions. But even under 6 centimeters, there is still a substantial percentage of patients who die from rupture. The second is pathology. The dissecting aneurysms rupture more readily than non-dissecting ones. And the third one is the rate of expansion. In our own natural history studies, we found that a centimeter a year expansion in an aneurysm is an ominous sign. Again, in the same study, we also found, besides the diameter, there are some clinical predictors of rupture. Older patients tend to rupture more readily. Presence of so-called non-characteristic pain is a predictor of rupture. So is the presence of COPD. And another study that we did not find, a renal failure was also found to be a predictor of rupture. So now we're in a little better position to recommend surgery to a patient that we have faced that has an aortic aneurysm. We know that there are other predictors other than just the diameter, the age, pain, COPD. Actually, there's a regression formula that will predict the risk of rupture within the next year for a given patient. Those you have to weigh against the risk of the operation. And we are in a little better position in 1999 than we were in 1997, for instance. Coselli has just published his large experience with thoracic aneurysms, and he has developed a regression formula that can predict the risk of the operation on a given patient for death as well as paraplegia. So you can look at a patient and put all these factors into the balance, and then you can say the operative risk is less than the risk of rupture, and you should be operated on. The ascending aorta, I'm just going to talk about the indications and the basic techniques. There are two broad categories of indications to operate on the dilated ascending aorta. One is mandatory or urgent indications. These are usually independent of size, and they are either related to dissection-related pathology, like acute dissections, intramural hematoma, or iatrogenic dissections, or endocarditis with annular destruction. The second large category, and which is the more controversial and more interesting aspect of this, is the elective or prophylactic resection of a dilated ascending aorta. And in this case, the indications are dependent on the size as well as the pathology. Again, the other four factors that play into this decision, whether the patient has Marfan's or related pathology, whether there is atherosclerosis with mobile plaque that may require elective resection of the ascending aorta due to recurrent embolization or during the course of other cardiac surgery, and the presence of chronic dissection. This is probably the most controversial of them all when you're faced with a dilated ascending aorta during the course of either operating on a bicuspid aortic valve or for other cardiac surgery like coronary bypass. When do you replace that dilated ascending aorta? Before we can talk about size, we have to define what is normal. Roman has developed a regression formula looking at a large number of echocardiograms, and in adults, 98% sensitivity will describe an aortic size of 2.1 centimeter per meter square. The body size usually determines the size of the annulus and the sinuses, and the age determines the sinotubular ridge and the ascending aorta. Why is size important in recommending operation on these patients? First of all, it's a very strong predictor of rupture. In all patients, the mean diameter of the aorta at the time of rupture was 6.1 centimeter. Again, in another study, the 6 centimeter was found to be the hinge point where the risk of rupture suddenly increased in patients with a dilated ascending aorta. Again, at the time of dissection, when you look at large series, you'll find that most of those aortas were dilated prior to dissection or right at the time of the acute dissection. In our own experience, the mean diameter was 4.8 centimeter at the time of dissection. And the third clue is dissection following the aortic valve replacement in a dilated aorta is quite common. If the aorta exceeds 5 centimeters at the time of the AVR, and the risk is almost 30%. Pathology is important too, because the risk of rupture is high in dissected aorta, and also the rate of expansion in dissection is higher than in non-dissected aorta. It's about double. And we also know that Marfan's with positive family history or new mutation are at high risk for spontaneous rupture. Especially in Marfan's patient, an aortic ratio of predicted to actual measured of 1.3 seems to be the cutoff where the risk increases. So this usually translates into a much smaller aorta than you would expect for ordinary indications for replacement. So current guidelines are based on these considerations. We've all been brought up in the culture of 6 centimeters, but it may be a little too late to operate on somebody with a 6 centimeter aorta. Because at 6 centimeters, 50% of them are already ruptured or rupturing. So you're going to miss about 1 out of 2 patients to this highly lethal complication. And the second thing that will push us against earlier operation is with the current techniques, the risk of surgery is much less. The third, the aortic valve, as long as the ascending aorta is only minimally or moderately dilated, can be spared, whereas in severely dilated aortic roots, it's hard to repair the aortic valve and preserve it. Again, the Marfan's experience shows us that this aortic ratio of 1.3 on an average size adult is about 4.2 centimeters, which is much less than the 6 centimeter that you would expect to operate on. So based on these considerations, this is sort of the tabulation that I came up with to recommend operation for these patients. Again, these are ratios, predicted over expected, expected over actual. And in Marfan's with family history, you'll be very aggressive because they rupture early. In chronic dissections, they fall about into the same category. Now, 1.5 is really the definition of an aneurysm. So degenerative with or without AI, if they have an aorta that is a ratio of 1.5, should be operated on. Another cardiac surgery, I put it a little conservative here, again 1.5. If the aorta actually is aneurysmal, it should be replaced at the time of the surgery, like coronary artery bypass or aortic valve replacement. Now, surgeon's experience obviously plays into this equation. If the surgeon is not confident about his results, maybe you can add half a centimeter to the diameter or 0.15 to the ratio, which will bring up the indication is a little bit more on the conservative side. Now, the basic techniques and alternatives. This is the gold standard composite valve graft replacement in its all three forms. This is the one that we use most commonly. It's the classic description and the Cabral modification for unusual situations. More recent technique of valve sparing root repair, Yakub or David modifications. You can replace the aorta and the aortic valve separately. You don't have to replace the root, everybody. Pulmonary autograft or the Ross procedure is an option. And then again, in very old patients, high-risk cases, aortic root wrap or aortic with or without plasty is an option that should be considered. Before one chooses one technique over the other, one has to also consider why one should be better than the other. And there are a number of factors that go into this equation. Obviously, the age and an anticipated survival of the patient is very important. You wouldn't want to wrap an aorta that has in a patient that has a long life expectancy, whereas in an older patient that may be perfectly acceptable. Again, the pathology and the quality of the aortic valve wall is important. Marfans and dissections, they need total excision and replacement. The quality of the valve, the annulus and the sinuses, and the size of the sinotubular ridge, they all have to be taken into account whether a certain technique can be applied. Especially the distal aorta is important to consider. If you're going to have to operate on the descending aorta, you would want to have a perfect result at the root, because some of these patients may require deep hypothermic circulatory arrest, and then even a little bit of aortic insufficiency may complicate their operation quite significantly. Obviously, the anticoagulation risk will force you to lean towards a valve repair or a bioprosthetic valve. Now, these are the options and what we would use. I'm not so sure there is a consensus in this, but I just tried to list them. If the annulus is normal and the sinotubular ridge is also normal size, in an old patient, separate aorta and separate valve replacement, or separate valve with an aortic graft is quite acceptable options, because since the patient's life expectancy is not long enough for the remaining tissues to dilate, you wouldn't worry about the long-term result. Whereas in a younger patient with the same sort of situations, a Bental or a pulmonary autograft is the way to go. Pulmonary autograft will depend on the size of the annulus. If the annulus is dilated, pulmonary autograft probably is not a good idea. Again, if you have a perfectly normal valve, a normal size annulus, or a dilated sinus or sinotubular ridge, then a valve-sparing operation is the ideal procedure for this patient. In Marfan's patients, we tend to use the Bental procedure because we worry about the fate of the valve because of the involvement of the valve with the same fibrillin defect that's on the aortic wall. And in those patients, we would recommend the Bental, but others would use a valve-sparing operation. Now, these are the basic techniques. Quickly, classic Bental procedure. The problem with that is bleeding into the wrap through the side-to-side coronary anastomosis. Rarely ever used nowadays. The Cabral modification was introduced to deal with that problem. Instead of doing a direct side-to-side anastomosis between the coronaries and the graft, an interposition graft is placed between the coronaries and the main graft, and the whole thing is then wrapped. This operation we reserve for only complicated cases where it's difficult to isolate coronary buttons. The buttons modification of the Bental procedure is the one that's most commonly used. The coronary orifices are dissected on surrounding aortic tissue as buttons and directly implanted into the graft with complete excision of the ascending aorta. This is the most reliable and most widely utilized form of the Bental procedure nowadays. And this is the gold standard with all the other procedures are measured against. Now, these are some of the newly introduced techniques. You should know all about them. This is David 1. It's the reimplantation of the aortic valve into a graft. These sutures are passed through the annulus, graft brought down to the annulus, and the valve, after total excision of the aorta, is then sutured inside the graft, and the coronaries are reimplanted. This preserves the aortic valve. To be able to use this valve, you have to have a normal-sized annulus. This is the type of the valve-sparing operation that we prefer. It's initially was described by Jakub, was really popularized by David, and it's called David 2, or the original Jakub operation. It's a little different than the David 1. In this one, as you can see, the graft goes down into the sinuses, and the valve is directly, the remnant of the valve, and the commissures are directly sutured to the graft. The valve is preserved, and the coronaries are reimplanted. This can be done not for all three sinuses, but selectively for dilated sinuses only. Actually, in David's experience, of 73 patients, only 41 had three sinuses reimplanted. In the other ones, one or the other two sinuses were not included in this. As I said, the Bental is the gold standard, and these are the results from the largest series in the literature. As you can see, the mortality varies between 6 and 10%, and the survival between 5 and 10 years also varies between about 60 to 80%. Now, I'm not going to say a whole lot about the aortic arch and the cerebral protection. For the sake of time, I'm going to skip that, but suffice it to say that most people will finally agree that retrograde Cerebral perfusion does not supply the metabolic needs of the brain, even at deep hypothermia, but it may be a very efficient way of cooling the brain, and therefore it may give you a little bit more prolonged time under hypothermic circular arrest conditions. Now we go on to the descending aorta and briefly talk about spinal cord protection. As we all know that this is a dreaded complication of descending and thoracoabdominal aortic surgery, and the highest incidence is in type 2 Crawford classification. This is one classification you should all know for your boards. The spinal cord blood supply is a little difficult to analyze because of the complex anatomy of the blood supply, and it has many sources of inflow. It's susceptible to steel, and it has an inbuilt tolerance to relatively long ischemia as opposed to the brain. We also know that the cord neurons may tolerate ischemia between 20 to 30 minutes with apparent complete recovery. Obviously, white matter and the tracts tolerate much longer time periods of ischemia. If you place a cross clamp proximally, the flow does not go down to 0. It goes down to 1.8 millimeters per 100 gram. And the minimum flow to prevent paraplegia is calculated by primate experiments was 4 to 10 milliliters per 100 grams. So these three facts make it a little bit more difficult to interpret what happens when you operate on these patients, why some get paraplegia, some don't. This is our interpretation of the literature and understanding of the physiology of spinal cord ischemic injury. As you see, there are three major sources for blood supply to the spinal cord: left subclavian, the middle portion, and the hypogastric arteries. We as surgeons have mostly concentrated on the middle portion. It's part of the guilt complex, I would say, because this is the area that you resect. And when the patient ends up paraplegic, we always blame it that we got rid of the blood supply from this area. But if you look at the reality of the thing, is the lower and the upper portion may be as important as the middle portion. There is that your baseline blood flow, 20 mLs, and there is your critical threshold between 10 and 4 where you get paraplegia. And if you get rid of that middle portion, but if you preserve the proximal and distal, you have a little bit of margin which will keep you above that threshold that will give you paraplegia. This has been the problem all along in trying to understand what really happens to these patients. We have very good evidence that this is so. In our series, if you took less than 10 intercostals, there was no patients with any injury at all if you had used consistent distal perfusion. In other words, you preserve the inflow from here and preserve the inflow from up there, but you can get rid of the midsection. But there is a limit to it. You cannot take more than 10. If you take more than 10, then the incidence of paraplegia dramatically increases. So what does that mean? That means if you take 10 intercostals in the middle, you end up with a cord that is precariously supplied with blood that will prevent paraplegia, but they will not prevent paraplegia in the postoperative period if you get hypertension, hypoxemia, or any other insults on the cord. So therefore, you have to preserve the middle section by reimplanting intercostals if you have to take more than 10 intercostals in the middle. These are the determinants of spinal cord ischemia. If the total inflow is below that threshold of 10, which is determined by where you put your clamp, how much aorta you resect, what the proximal perfusion pressure is, and what the CSF pressure is. All these things determine that. And the second, the length of the ischemia. That is determined by the clamp time. Third, the severity of the ischemia, whether there is still, these intercostals are bleeding back into the field, even though you're supplying blood proximal and distally, but they're losing it in the middle. And also the fourth, what happens after you finish the operation. After you finish the operation, your total inflow should be at a rate that will maintain the cord and pay back the oxygen debt. If you cannot accomplish this, then you'll end up with paraplegia. So what do we do to prevent this? We do not clamp the left subclavian artery at all costs. If you have to do that, you have to use deep hypothermic circulatory arrest. For the middle section, you have to reimplant intercostals if you're going to take more than 10 pairs. You can use heparin or prostaglandin to dilate the collateral sources to give you more blood supply to this middle section. And more importantly, I think this is the thing that we have been neglecting in the past, is use of distal perfusion. You have to use distal perfusion to increase the perfusion pressure from the distal sources, and you can supplement it by CSF drainage, which will optimize the perfusion of the entire cord. So this is our technique, and this is the rationale behind it. We use TSDA in order to avoid clamping the left subclavian. We sequentially sacrifice the middle vessels, the ones that are going to come out, in order to allow for compensatory increase from other sources and maybe produce pre-ischemic preconditioning. We always use distal perfusion, and that is the right answer when you go and sit for your boards. You have to use distal perfusion when you do descending aortic surgery. You can't do it in 5, 10 minutes, 15 minutes. You have to use distal perfusion. And then we use CSF drainage to optimize the cord perfusion. Now, this is an outside confirmation of what I just told you. Safi, in a large series of patients, has compared Crawford's original series and his series without any adjuncts with those that he has done with distal perfusion and CSF drainage. As you can see, the distal perfusion and CSF drainage buys you time, but it does not abolish the incidence of paraplegia completely. If you don't use any adjuncts, you have less than 40 minutes. You end up with a significant amount of paraplegia. But you look at the slope of this curve and these two curves, after about 80 minutes, they are identical. That means the cord is dying slowly after 80 minutes in spite of having used these things. And the only way to get around this is deep hypothermic circulatory arrest. That will buy you more than 80 minutes. So these are the results in the most recent series with adjuncts. You see the addition of adjuncts has reduced the incidence of paraplegia in the high-risk cases. These are the type 1s and type 2s, from 38 to 14% in Safi's experience, and in our experience from 33% to 9%. And this is where we stand today in the surgery of descending and thoracoabdominal aorta. Extent of resection and clamp time still are the most important determinants of risk, the risk of paraplegia, that is. With the exception of TSDA, the current protective methods are inadequate for prolonged times. Over 80 minutes, you still have that risk of cord dying slowly, no matter what you do to protect it. Now, the most important thing probably that the solution needs to come from this. The current methods of reimplantation probably are not reliable. One, they prolong the intraoperative cord ischemia, and two, maybe they don't stay open postoperatively the way they perform them now. So we have to improve in this area. So what I did is I tried to give you an overview and give you some of the controversial areas, and I hope that will help you with your boards. Thanks.